So, today we're going to talk about colchicine. And there are several things that get wrapped up in this issue. Why aren't people taking off with it? Let me go down and talk about this. There was a study recently with some editorial comments about colchicine, and they said, look, this stuff is great. It's a wonderful way to decrease cardiovascular risk. But why aren't people taking it? Let me go back in terms of time and history on this issue. Paul Ridker and Gavin Blake are a couple of physicians, smart guys at Harvard, Brigham and Women's. And this was like 20 years ago. They started looking at the data, they started looking at the evidence, and they said, this is interesting. Everybody thinks LDL causes cardiovascular disease, heart attacks. But when we look at the actual evidence, it looks more like whether or not they're on a statin does that. So, and it doesn't matter if the LDL is low or the LDL is high. Being on a statin seems to be more of a protection than low LDL. And then they started thinking, well, maybe there's something else going on here. Maybe statins actually do something slightly different or something other than lowering LDL. Sure enough, they got deeper into this and they started seeing that statins decreased cardiovascular inflammation. What is that? Most docs don't entirely understand it, but it's like inflammation anywhere else, in a wound or, again, anywhere else. It's our immune system attacking something. In a wound, it's attacking infection. With gout, it's attacking inflammation of the joint due to uric acid crystals. In COVID, in the lungs, it's attacking infection. So, what do you do about infection? Again, your immune system attacks it. Sometimes the immune system, like with COVID, ends up being more of a problem than the bug itself. That cytokine storm that we talked about when we were in the midst of the COVID, the worst part of the COVID pandemic. So, inflammation is a big deal. For most docs, we still have trouble wrapping our head around inflammation may actually be the bigger cause of heart attack and stroke. Now, it was very interesting when he started coming out with studies. Paul Ridker, did what you might expect. After the experience that I described earlier, he started looking at things like, one of the first things was a thing called canakinumab, Ilaris. That's one of those really unusual drugs. It was like $80,000 a year. It's an injection, and it's given for a very unusual disease, a juvenile inflammatory arthritis. But because it impacted inflammation, he was able to get funding to try it. And sure enough, what happened? It decreased heart attacks and strokes. When you see the cardiology community around the world react to it, they said, dang, we sort of at least theoretically knew that inflammation caused this problem, or was an area, but we disconnected on it. In fact, if you go back and you look at things like the cover of Time magazine in 2004 and the cover of a couple of cardiology magazines, again, also in 2004, they all were very clear. Inflammation causes heart attacks and strokes. But as you see, you would think, well, maybe that would change from cardiology community from doing basically plumbing, where you look to see if the pipes are open, and then if they're not open, you take a roto-rooter and try to clear them out. If the pipes are open, you look at them. That's using an angiogram. Take somebody to the cath lab. If the pipes are not open, then you take the roto-rooter or the stent and try to clean them out. If inflammation is really the problem, then why do we continue to focus on plumbing? Well, there are two reasons, and we've talked about them many times. One is they don't know what to do about the inflammation, and that's where colchicine comes in. The other is there's a whole lot of people paying their mortgages by doing stents. That's just the bottom line. There is a major medical industrial complex wrapped up around the plumbing side of cardiovascular disease, despite the fact that there's so much evidence to indicate that it's really inflammation. Let's go back to the first thing that we mentioned in the title for today, colchicine. Well, let me go back and just describe another experiment, another set of studies done by Paul Ridker, that first fellow that helped to discover this. He said, well, there's a lot of anti-inflammatory drugs out there. There's steroids. Those are anti-inflammatory drugs. There's non-steroidal anti-inflammatory drugs. And he actually did studies to look at those. They didn't work. But he continued to look at this. They did look at statins. And yes, statins did decrease cardiovascular inflammation. And one of the good things about that was statins did that in very low doses. You didn't have to have these high doses like 10 and 20 of Crestor or 40 and 80 of Lipitor to impact it. You ended up being able to do that with much lower doses that didn't trip off nearly as many side effects. But he still wanted to look at others. He did Alaris. And a few years ago, it was like 4 or 5 years ago, they did a study with a medicine that was being used or had been used in the old days quite a bit. A medicine made from a crocus plant, you know, the little flower, the crocus flower. A medicine called colchicine. Now, that medicine wasn't used very much anymore. It used to be the treatment for gout. But we found that we, meaning doctors, found that we could get much better impact with many, many fewer side effects. And the side effects they're an issue. They're still an issue, even when you come to today. So 7 years ago, when that study was done, and Paul Ridker found that colchicine actually decreases cardiovascular disease or heart attack events. I remember seeing that thinking, oh, this is so interesting. Again, the cardiology community throughout the world reacted the same way they did with every one of Ridker's studies. Dang, we knew that inflammation was an issue, but it just seemed theoretical. And then they would go back to doing their cath labs and stents. And I kept thinking, wonder when colchicine's gonna hit the prime time. But again, there's side effect issues. And let me just take a minute and read you some of the side effects. GI side effects, gastrointestinal side effects are by far the most common. Diarrhea, nausea, cramping, abdominal pain, vomiting. In 1 to 3/4 of people that take the medication. In fact, that's a lot of people. Fatigue. You can actually even get gout in some people. You get pain in your jaw, your throat. That's not common, 2 to 3%. Headache, 1 to 2%. Neuromuscular toxicity, muscle pain, weakness, myelosuppression, meaning loss of the function of your immune system. Even disseminated intravascular coagulation. What does that mean? You remember the thing that was killing patients back in the days of COVID, that cytokine storm? That was resulting in DIC, or that disseminated intravascular coagulation. That's a big, long set of words. Don't worry about remembering it. What happens is your body gets into a space where it's just forming clots all over your body. And that is often lethal. So, to get back to the side effects of colchicine, there are more. Loss of hair, purpura, which is a purple discoloration of your skin, rashes, more GI problems like milk intolerance, abdominal cramping and pain, again, vomiting, nausea, diarrhea, loss of immune cells. Again, some of these start to get repetitive, liver inflammation. So, again, multiple problems. That's why, as a medical group, doctors got away from treating gout with colchicine because you could use something easier, the non-steroidal anti-inflammatories, and something with far fewer side effects. But along comes this study by Paul Ridker, and again, it raises the question. I'll read some of the comments about that study in just a few minutes. But I'm not quite done with the problems with colchicine. There's a whole list of medications that you really should not take when you're taking colchicine. Let me just read a few of them. Amiodarone, clarithromycin, cyclosporin, different types of antibiotics, diltiazem, erythromycin, more antibiotics, ketoconazole, which it's sort of an antibiotic. It's an antifungal drug. It's very popular. I've had a dermatologist recommend it for me for some of my issues with skin cancers. Omeprazole, the ulcer medications. Proton pump inhibitors is what you call them. Nifedipine, paroxetine, reserpine. Guess what? Verapamil, things like that, the ACE inhibitors that we use for blood pressure. And last item, guess what? Even statins. So you start looking at all these relative contraindications, these warning signs for colchicine, and you begin to understand why the medical community is just so hesitant and moving so slowly with colchicine. Now, I told you I was going to go back and talk to you about the study, the recommendations, the guidelines for colchicine preventively. About 10 or 15 points, and let me just go through them. Colchicine 0.5 milligram daily is now approved for prevention of cardiovascular disease, secondary prevention, not primary. If you have questions about that, I can share that. The recommendations are rooted in the findings of studies called LODICO-2 and COLCOT, if you have an interest in looking those up. They saw very significant improvement in cardiovascular risk, 31% drop in events with patients with stable atherosclerosis, plaque in their arteries. There was a similar drop of 23% in patients that had had a recent heart attack. So the evidence is that colchicine does work. It is helpful. Now, the guys that made the recommendations made a big point of delineating or differentiating the doses. The dose that they're talking about for this, the lower dose is 0.5 milligrams once a day for prevention. They say, we saw few, if any, side effects. In fact, we think we saw about the same number of side effects that we saw with placebo. And it's very, very different from the dose that you use for gout. Well, the dose for gout is 0.5 milligrams, but it's twice a day as opposed to once a day. They acknowledge clinicians will be hesitant to use this lower dose of colchicine just because we're not used to using colchicine at all, because we had better medications for gout. The review looked into a 20-year experience of continuous use of colchicine. The main finding was that it was appropriate. Patients had side effects about the level of placebo. Now, there was minimal evidence, at least in their opinion, that colchicine increased the risk of serious fatal infections, which it can, and which happened with that other drug. You remember the injectable drug, the canakinumab, with that long name for juvenile inflammatory arthritis? Yep, it did the same thing. That's one of the many reasons that you don't see canakinumab being used for cardiovascular prevention. Patients on low-dose colchicine often report diarrhea after the medication is started, but it does typically resolve, and that's over the next week or so. Now, we're starting to get questions because people are starting to read. Our patients are very, very smart. They're very studious. They understand. They take their cardiovascular disease in their own hands. And it's because they understand they have to. 3/4 of doctors in US, which is by many people's opinion, maybe the best healthcare manpower group in the world, still 3/4 of the docs in the specialties that are supposed to be informed about this and taking care of patients with cardiovascular risk don't know how to how to make the diagnosis of the most common cause for cardiovascular risk, metabolic disease. So again, something like colchicine comes up, it's going to be a while before docs start using it. I've seen it myself. I've been very hesitant because I haven't used it in the past for gout. We're starting to use that now for patients. How do we do it? How do we make that decision? Do we just tell everybody that we think might need it, go ahead and take it? That's not our style. That's not what we do. We inform our patients. We see our patients as they're Luke Skywalker. We're just Yoda. Luke's got to fight his own battles, but we have a lot of ways. We've been in a lot of these battles with a lot of people, and we have a lot of ways to support you. One of the biggest ones is giving you the details, helping you know what the risks are, what the benefits are. And unfortunately, when they're not completely known, we make you aware of that too. So I'm going to stop that at this point, and we'll see if we can do a few. Got a lot of interest today. I'm not surprised. Again, we've been getting a lot of questions about colchicine. JMK. In case you haven't noticed, I'm going to go into some Q&A, respond to some folks here. JMK is always attending and asking good questions. Let me see if we can get that on the screen. If a male type 2 diabetic with known coronary artery disease had an albumin and creatinine ratio of 15, GFR of 7, would that preclude the daily use of low-dose colchicine? Clearly, the lower, one of the things, and I don't even remember if we read it in that long laundry list of colchicine problems. Kidney disease, you don't want to take colchicine. Clearly, if it's 45, your GFR, no, I wouldn't take it. 70, again, that really starts to get right at the edge. And that would be something where we would talk with our patient. We would do a full analysis of the patient's risks and benefits, risks of taking colchicine and the risk of not taking colchicine. I can see us giving that for folks. Okay, Joe XSM. I saw that colchicine has very tight dose restrictions, easy to take, too much, causing harm. Exactly, that was my point, Joe. Thanks for the update. Okay, Canuck PI. Canuck PI is a member. Thank you so much for joining. In a past video, you mentioned albumin urine random. I think you're talking about microalbumin creatinine ratio. It's a valuable marker for arterial health. How high would you rate this, and why hasn't anyone else on the internet mentioned it? Well, it's interesting, Canuck. I think it's one of the more important indicators. people mention it, but you may not pick up on it. They're talking about kidney function. Um, the most common cause of people losing kidney function and having to go on dialysis is diabetes. And what we're looking at are very, very early impacts of prediabetes and diabetes on the kidney. That's what we're looking at with this number. I hope that makes sense. For those of you who are looking at that, asking questions, let me give you a couple of components. We've talked about inflammation a lot today. The key place where inflammation is a big deal is the lining of the artery wall. There's a lining. It's a little hairy substance, and it's like if you've gone to the beach and you've ridden through the marshlands, it's sort of like the marshlands components of our body. It's where the things like oxygen from the red cells is dropped off, and things like waste products from the cells is picked up. Things like lactic acid. When you go into a photo micrograph video, you can see the capillaries, and the red blood cells are so small that they're going through like donuts and brushing against the villi, or the marsh of the marshland, that lining of the artery wall. It's got a consistency about like snot, mucus. So it allows those red cells to pass through. Now, you don't want that very delicate lining of the artery wall to get burned up. Having glucose 140 or higher, hour after hour, day after day, tends to irritate and then just burn that lining. That's when we start to see plaque form underneath that lining. It doesn't form on the inside of the artery wall. That's what most people assume. The LDL goes through this injured or irritated lining, and then it gets stuck underneath that lining, between the lining and the muscle layer of the artery wall, which provides the structure. So I hope that's helpful. Ask again in a different way. And as Jesus has said, we're going to work to start getting better answers, even recorded permanently for members of the channel. Joe, speaking of members, Joe XSM is a member, and I hope we got your question answered, Joe. Let's see what else we've got here. Gosh, we got a lot of questions. Let me see if I can find. Let me see another one from Joe XSM. When you say secondary prevention, for secondary prevention with colchicine, do you mean having? Oh, that's a great question, Joe. So that gets into an issue which we covered in the aspirin video. And if you haven't seen the aspirin video, go take a look. It's rapidly become our most popular video. You know, like many of these things, like the egg video, it surprised me. But it surprised me because so few people really understood the details behind aspirin. One of the key details was exactly what you bring up, Joe: secondary prevention. Now, here's what happened with aspirin. And I'm going to go down the aspirin bunny hole for just a second, and then you'll see how it applies to your question. With aspirin, you may remember back prior to 2020, 2021, 22, that era, the U.S. Preventive Services Task Force and most of the standards committees for prevention in cardiovascular disease used to say, well, once you reach 60 or 65, everybody should take a baby aspirin. Well, then a few years ago, you got the summaries, the reporting out of New York Times, and the journalist for the New York Times for medical stuff is good. He understands medicine for the most part. He's a pediatrician, but he didn't understand the concept of secondary prevention very well. A few years ago, the U.S. Preventive Services Task Force looked at aspirin and looked at primary versus secondary prevention. And what they said was, we don't really recommend it for primary prevention anymore, but for secondary. Now, that gets to your question, Joe. What is primary and what is secondary prevention for cardiovascular disease? Primary is you just reach a certain age and you start. So, for example, a CIMT, for example, could be a primary prevention intervention because CIMT has no significant negative impacts. Aspirin, on the other hand, it does have significant impacts. It can cause bleeding. So what they ended up saying was, look, for primary prevention, we don't really recommend aspirin anymore because the benefit risk equation doesn't matter or doesn't do it. It isn't as positive as it used to be. We do recommend it for secondary prevention. So I've gone at it from 3 or 4 different directions, Joe, and you see what the question's becoming. What is secondary prevention for coronary artery disease? The bottom line is, like Jesus loves to complain about, it depends. It depends on who you're talking to. I'm one of those people that would say, if you have plaque, you're into secondary prevention. Most people would agree with me. Most doctors would. If you've got plaque, you're now a coronary artery patient. And so anything that you're doing from that point on is secondary prevention. So when you hear a recommendation from a standards committee or a group of cardiologists saying, we think that you should take low-dose colchicine for secondary prevention, most of them are saying, okay, you get plaque, we think you should consider colchicine. So I knew that, as usual, it took me a while going through bunny holes to get to that. I hope that answered your question. 0.5 milligrams with 5 milligrams or 10 milligrams of rosuvastatin. Yep, that's what their recommendations are boiling down to. Yep, Tommy Lynn Laws doesn't trust doctors anymore. Tommy, I don't think that's inappropriate. Doctors are busy, they're people, they make mistakes. And the whole point behind what we do in our practice, and especially what we're doing with the YouTube channel, is giving you the information. Good, bad, ugly, or indifferent, we're giving you the right information that you need to make your own choices about something that's very important: your lifespan, your health span. So Gail 716, doctor, if you would, are you taking it as a secondary prevention? That's one of the key things that we will do in terms of helping you make your own decisions, make your own choices about an intervention. No, we're not. I'm not taking it yet. I may end up taking it some as a demonstration for people in my community. I feel very strongly about doing that. Do I feel strongly as a patient? I have plaque. I've shared that before. I have prediabetes, in fact, full-blown diabetes by some testing interpretations. Do I take colchicine? I don't. I probably will at some point, not so much because of my own concern about risk, but because of supporting the channel. Okay. Let's see. Again, a lot of other questions, and I'll see what I can cover for just a couple more minutes, and then I'm late for another appointment. Goran Kondrik. Does it make sense to combine with a Goran? I'm guessing you're saying, does it make sense to combine statins and colchicine? And I think a lot of people are saying yes, it does, even though there is some relative contraindication. Again, we're not talking about minimal decreases in risk. We're talking about, as you remember from what I read before with the Colcott trials and the other ones, Lodico, we're talking about 23 to 31% decrease in risk. So I guess that may bring you back to the question that somebody asked me a few minutes ago, Gail, 716. Well, then why am I not taking it? Because I'm one of those folks that I think I'm in a totally different risk category. The vast majority of patients that have cardiovascular risk, already have plaque, are patients that are not managing their metabolic disease. When you look at my metabolic disease, I've taken that risk completely off the table. My A1C is in the low fives. My fasting glucose tends to be in the mid 80s. I've got my triglyceride over HDL ratio tends to be about 1/2. So I don't see myself as having major cardiovascular risk. I've taken the vast majority of it off the table. Now, if that's the case, why would I want to take another medication like colchicine with all of the reactions that we've seen and heard and talked about? I may do it at some point. As I said, the first reason and the major reason for me right now would be as a demonstration for my my viewer community. We're getting more and more interest in this topic. I'm going to go ahead and cover just a few more, and I may be a little bit late to my next meeting. So, Goran, a member, thank you for joining again, Goran. Does it make sense to combine low-dose statin, low-dose colchicine, baby aspirin for the sake of handling soft plaque and reducing inflammation? You know, Goran, you actually brought up another couple of components. We're not talking just about low-dose colchicine and low-dose statins. We're also talking about with baby aspirin. But you're also bringing in yet another component, and that is soft plaque. If I had soft plaque, it would be a little bit different. And I would say, yep, I think that probably is worthwhile. And I would go ahead and add the colchicine, the low-dose colchicine at that point. It's a great point, Goran. I appreciate you bringing it up. And if you're a patient, if you fit those criteria, or if you're in a position where you'd like to talk more about low-dose colchicine, let us know. DG, do you see prediabetes as a threat to health? Doctors seem to blow it off. I see damage happening to the mitochondria and the blood vessels and arteries. I have a CAC score, a calcium score of 451, age 67, A1C of 5.5. So DG, people are going to think I put you there as a shill in the audience. I mean, I don't know if you've already heard what I just said a minute ago. In my mind, the biggest killer and disabler, not just in the US, clearly in the US, but the rest of the world now too. There's a lot of bad things that are going on in the world, but we're sort of like frogs that have been boiled slowly. We just sort of think it's okay to be in a world where we can have a heart attack and wake up dead. Half the time that you have a heart attack, your first symptom is death. We think it's okay to live in a world where that happens in your 60s, even 50s, not the 90s. We think it's okay to live in a world where stroke, another vascular disease problem, you call it cardiovascular disease, so it confuses the heck out of everything, but it's another vascular disease problem. Stroke, the #1 cause of permanent disability. We think it's okay to live in a world where that happens. We get, I mean, in the US, we got focused on the Vietnam War, and we have the Vietnam Memorial. It's very dramatic, very beautiful, and it's very sobering. But on the other hand, we have the same number of deaths as the entire Vietnam War every 2 weeks in this country alone. And we think it's okay. Why is that? We're obviously not managing metabolic disease very well. And again, it's not just me. It's not just me saying that doctors don't know how to diagnose prediabetes. It's in the science. It's been studied and shown multiple times. We're not talking about orthopedists. We're not talking about surgeons, neurosurgeons, people that don't have to manage cardiovascular disease. We're talking about the doctors that are responsible for cardiovascular disease, family practitioners, internists, and cardiologists. Studies from Hopkins, Mayo, other places are very clear. 3/4 of those doctors in those specialties that have trained in this space do not know how to make a diagnosis of prediabetes. So you have to ask the question, what are they doing? Well, let me just look for LDL and treat that and move on to the next patient. Yep, DG, you got me going. And yep, I'm going to be late for my next appointment. Thank you so much for your interest. And I'm going to have to leave. I'm sorry. Again, Jesus, I know, is in the background. I know he's been supporting from the back, but I'm going to need to go. Bye-bye. And don't let Tony the Tiger take over your kids' dinner.